Hi guys, next up is rheumatoid arthritis, and this is not to be mixed up with rheumatic arthritis that is seen in children after recurrent sore throats which are caused by group A beta hemolytic streptococcus. Moreover, rheumatic arthritis responds to aspirin, but the current topic that I am teaching you, rheumatoid arthritis, will be talking about usage of DMARDs, that's disease modifying anti-rheumatoid drugs. I'll be describing management with triple therapy. Yes, traditionally we did triple therapy with H. pylori, but I'm going to describe triple therapy for rheumatoid arthritis as well. Then I'm going to talk about biological DMARDs and then targeted synthetic DMARDs like baricitinib and tofacitinib for management of this condition. And before I get into the specifics of the disease and highlight before you what are those key points in a question that you need to identify, I would like to just draw your attention to the two images which have been asked in the exam in different sessions. In the first image, you can see the classical deformities of rheumatoid arthritis. It's a erosive arthritis. In contrast, rheumatic arthritis, the one that is seen in children with group A beta hemolytic streptococcus, that's a majority of cases non-erosive arthritis. If you're having issues at this juncture, I would like you to go to the rheumatic fever section in cardiology so that you can get a better idea regarding rheumatic arthritis, and currently we're focusing on rheumatoid in this image where you can see the small joint involvement. In rheumatic, it is large joint involvement, ankle joint, knee joint. The traditional word is migratory polyarthritis. But here I'm talking about small joint involvement and the deformities in the hand. And you can notice the classical Z-line deformity. You can also see the Boutonniere deformity that is present. So per se, I can say image number A will be very easy to identify. In a different session of the exam, he began by describing a female patient because, all rheumatic conditions are more common in women. Then he asked us to make a spot diagnosis, and a couple of guys casually answered this as swan neck deformity. But you will notice that one, the deformity is present in only one finger in the hand, and the remaining hand looks relatively okay, looks to be a hand of a relatively younger person. And moreover, you will notice that there is no extension at the proximal interphalangeal joint. The PIP of the patient is in a neutral position, and where I'm putting my star mark, there is a flexion at the distal interphalangeal joint. Guys, this is a sports related injury. I'm very sure you guys have identified it even before I would have started writing the details with respect to this. The image number B that I mentioned at the moment is a spot diagnosis with respect to mallet finger, which is a sports related injury, whereas image number A, which is shown on the current slide, would be answered by you as the classical erosive arthritis that we read in rheumatoid arthritis. Now, as far as the clinicals of the disease are concerned, we will notice that the incidence of the disease tends to peak between 20 to 55 years of age. Then between 55 to 75 years of age, it tends to the incidence of, that's the new cases basically, the incidence tends to remain static, and then it tends to show a declining trend after 75 years of age. So most of the time the question will be describing a young female, and the question may not straight away begin by describing that classical morning stiffness lasting for more than 1 hour with that PIP MCP wrist joint, that classical small joint involvement given. In fact, the question might try to waste your time by a bit by writing down constitutional symptoms as well. Though constitutional symptoms can precede the development of arthritic manifestations in a couple of patients, it is not a guarantee that all cases will be having constitutional symptoms. Constitutional symptoms, if given in a question, would be in the form of low-grade fever, they would be fatigue, malaise. In fact, in some cases, they can even be full-blown depression, even cachexia described in the case as well, though it is not a guarantee, but constitutional symptoms can be present in cases. I've written plus minus to say may or may not be seen. And now let us focus on what are those keywords in a question that would help you identify that, okay, I'm dealing with rheumatoid arthritis. The keywords as I described were that this would be a young female. She says that, doctor, I'm usually late for my work. In the morning hours when I get up, there is so much of stiffness in my hand that even holding a toothbrush and then doing routine household chores is a Herculean task for this lady. So there would be early morning stiffness lasting for a duration more than 1 hour described in this case. And this lady will also say that, today there was an important meeting in my office. So my boss had said that you have to be on time. So once I started, getting ready for work and started fixing my breakfast, taking a bath, etc., then she says that the early morning stiffness will tend to ease with physical activity. So that is one feature that you have to identify. And at this juncture, I would also like to say that if the question begins by describing a young male and then he says early morning stiffness, and then says low backache, then you have to think in terms of ankylosing spondylitis, which has been discussed separately. If you scroll down in the app, at the moment I'm focusing on rheumatoid arthritis, which would be young female with early morning stiffness, with easing of this early morning stiffness with physical activity. Now, as far as the joints in this condition are concerned, it would be the small joints of the hand which are involved, and the involvement will be bilaterally symmetrical. Before I write down those joints, I would like to reiterate my statement that in rheumatic arthritis, it's going to be large joints like ankle joint, knee joint. It's going to be migratory polyarthritis. It's going to be an asymmetrical involvement, and it's going to be large joint involvement. Whereas in rheumatoid, it's going to be small joints of the hand. That's going to be proximal interphalangeal, metacarpophalangeal, and the wrist joint. And this is going to be a bilaterally symmetrical involvement. Now, when you will monitor this patient, you will notice that in a single consult, it may not be that in today's consultation, she is having pain in both the wrist joints as well as the MCP as well as in the PIP. In today's consult, the pain might be present only in the wrist joints. In the subsequent consult, the pain might be lesser in the wrist and might be shifting on to the smaller joints in the hand. So you need to monitor the patient over a duration of a couple of weeks. In the later part of this video, you will hear me talking about the classification criteria for this condition where duration also matters. So you need to monitor how many joints are finally getting involved in these patients. The reason for doing that activity is because you need to classify. Is this a case of monoarticular rheumatoid arthritis? Is this a case of oligoarticular rheumatoid arthritis, or is it a case of polyarticular rheumatoid arthritis? Because the number of joints involved in each one of them would be different. Monoarticular, as the name suggests, implies single joint. Oligoarticular would mean that at least less than 4 joints would be involved, and polyarticular would mean that at least 5 or more than 5 joints would be involved bilaterally, symmetrically. However, in some questions, you will notice that he might even talk about involvement of the small joints of the foot, that is metatarsophalangeal joints. Now, you're aware that why he's doing that is because he wants you to get distracted towards gouty arthritis. Gouty arthritis will usually be a flare-up. The triggers for that could be alcohol binge drinking. It could be in the form of usage of diuretic for management of hypertension. And then there would be elevation of serum uric acid. There would be elevation of uric acid in the joint space. And ultimately, the flare-up would occur and the manifestation would be called as podologia or podagra. But in this case, also, MTP involvement can be described in a question. Also, do not be surprised if you read about DIP involvement with respect to patients of rheumatoid arthritis, because in old age, we usually tend to have osteoarthritis developing in these patients as well. I mean, osteoarthritis is anyway a geriatric disease. So as a rheumatoid arthritis lady will become older, DIP involvement can be seen. This is due to old age. This is due to concomitant osteoarthritis in a patient. I repeat my statements here. One statement I would like you to pay attention to is that MTP involvement can be given in a question of rheumatoid arthritis to distract you towards gouty arthritis, but then the flare-up of acute gouty arthritis is totally different. The description would be totally different. In fact, the redness of the first MTP would be like, it would just mimic cellulitis. The skin would be extremely red. It would be inflamed. Even the bedsheet, if it would be touching the skin in gouty arthritis, is gonna hurt. And second, I said DIP involvement can be given in a question of rheumatoid arthritis in patients as they grow older because of the concomitant osteoarthritis, which tends to involve the distal interphalangeal joints. The clinical hallmark of this condition, like I was speaking about pathological hallmark, that is PANOS, the clinical hallmark would be flexor tendon tenosynovitis. And because of this, there would be a decrease in the grip strength or the hand grip of this patient. Or if this young lady has to open a bottle of a jam, if you have to open a bottle of a jam, if you have to unlid the bottle of a jam, you need a bit, you need to hold the top part and then you need to unlid it. And that's where this flexor tendon tenosynovitis can be picked up. Ultimately, if we do not treat these patients aggressively, deformities will develop, though nowadays the incidence of deformities has decreased due to the aggressive usage of targeted synthetic DMARDs or biological DMARDs, as we will be discussing subsequently. One of the classical deformities of this condition is a swan neck deformity. As you can notice in this figure, there is an extension which is present at the proximal interphalangeal joint. And then you can notice a flexion where I'm putting an arrow, that is a flexion at the distal interphalangeal joint. So the first image which you can see at the moment is the very classical swan neck deformity. And now I think it is much more clear that in the previous image that I had shown on the slide number 1 to you was mallet finger, where there was no extension at the proximal interphalangeal joint. Now, if you contrast this with the second image, you will notice that you just have to use English and invert the words here. You can notice a flexion at the proximal interphalangeal, and you can notice an extension at the distal interphalangeal, and this would be Boutonniere's deformity. At the moment, I know this Boutonniere deformity thing would be looking very easy to you, but in the actual exam, I've seen people floundering because that flexion, extension, flexion at different joints. It can cause a bit of an error of judgment. So I would just like you to keep patience here and remember, and in fact, hand draw this with me. The like the lines that I've drawn here. One, I've shown a extension at the PIP and a flexion at the DIP. At least if you draw one of them, then the exact English of that is to be represented subsequently. That would be a Boutonniere's deformity, which has been shown in the subsequent image. And once you get these two right, then I would also like to draw your attention to the Z-line deformity. In fact, it's very prominent, the Z-line deformity. So for Z-line deformity, most of the time, if he's gonna ask you, he will ask what is the defect. And your answer would be given as that there is a subluxation, a very visible one, subluxation of the first metacarpophalangeal joint. And along with this, the second thing that you're noticing is a hyperextension. And where is this hyperextension present? It is being noticed at the interphalangeal joint. So the two together that are described, subluxation of the first MCP and the hyperextension of the interphalangeal joint, these two together are referred as a Z-line deformity. As I've said earlier, the incidence of these deformities is now becoming lesser because of the crippling part. If you look at the hand of this particular person, you will notice that it would be very difficult for this person to hold a glass of water or to do household chores. So nowadays we are aggressive with respect to management. In earlier times, we first used to give NSAIDs and steroids. And then if person was not responding to that, which they will obviously not, we used to use DMARDs. But now he says be aggressive in management from the initial part itself, so that the crippling arthritis, which hampers with day-to-day activity and causes, I would say, the morbidity component to increase, or I can say the quality of life of a person to decrease, can be substantially reduced. These are the keywords in a question for rheumatoid arthritis, but there are certain peculiarities as well that I would like to describe before you on my subsequent slide. The peculiarity that I would like to bring to your notice is one, a piano key movement of the ulnar styloid in these patients. That's again because of the involvement of the wrist joint and the erosions that are developing in the wrist joint. And the next one that I'm describing is devastating, because this disease can even involve the cervical spine. In fact, I would tell a patient of rheumatoid arthritis, you can do yoga, but do not try to do a headstand, because even the cervical spine is involved in rheumatoid arthritis, and there is a big time risk of atlantoaxial dislocation. So let me say, because this lady was always sick, she was having constitutional symptoms also, she was having pain in the small joints of the hand, somebody advised her to do yoga. She was doing very well in yoga, but then her yoga instructor, who's not a medico, instructed her to do a headstand, and he does not realize the dangers that he is exposing this lady to. Because of the vulnerability of the cervical spine in this patient, there can be atlantoaxial subluxation. This can contribute to compression of the C-spine, and thereby compressive myelopathy can develop. This compressive myelopathy can then result in development of even quadriplegia. In fact, this description that I've given before you in point number 6 was a question that was asked in the AIMS exam. Now we call it INISET, but formerly in the AIMS exam, they had given a description like this, that a young lady with rheumatoid arthritis who's always sick has been advised by somebody to do yoga. I mean, doing yoga is not a problem, but if she's gonna do too much of any exercise which is gonna put undue stress on her neck, like doing a headstand, then cervical spine involvement can be lethal enough to the level that this person can develop a compressive myelopathy. And the bad news is she'll end up with development of quadriplegia. Person might be even requiring ventilation. If the compressive myelopathy is at the level of C3, C4, C5, then you can understand the respiratory drive of the patient will also be affected. So quadriplegia can occur in these patients. That is why I was saying a peculiarity. Apart from this, I was saying that this disease predominantly involves the small joints. That's okay. But even the knee joint and the shoulder joint involvement, and even in some cases hip joint involvement has been described. Especially in the monoarticular variety of rheumatoid arthritis, large joints can be involved as well. See, in majority of questions is going to give you standard data, small joint involvement. But at the same time, I told you that you need to keep a watch on the involvement of the small joints can also be description, or small joints of the foot can also be given, and even the DIP involvement can be given, especially in the same patient in older age group, because osteoarthritis can be coexisting. So that is a point to be, kept a watch upon, which the diagnosis still rheumatoid arthritis, but the examiner is trying to shift our focus to alternative diseases. Similarly, here I'm trying to say that especially in the oligoarticular variety, it can be involvement of the large joints as well. That has to be kept in mind. And then we focus on the extra articular manifestations of the disease. In fact, most medicine questions would begin from here. Everything that I've said from point number 1 to point number 7 has been taught to you even in orthopedics as well. So there's nothing new that I've said, but especially from point number 8, it is hardcore general medicine data which I want you to pay attention to, and especially for the most common extra articular manifestation. The question of the previous year said, what is the most common extra articular manifestation of rheumatoid arthritis? Do not answer anemia of chronic disease. Yes, we do have anemia of chronic disease present here, but the most common extra-articular manifestation would be given by you as rheumatoid nodules. Now, where are you going to see these rheumatoid nodules? So they are mainly going to be seen on the forearm of the patient, or they can be seen with respect to the sacral prominences, or they can be seen with respect to the Achilles tendon. So I'll just repeat that fact once again. Rheumatoid nodules per se are the commonest extra-articular manifestation of this disease. Do not answer eye manifestations as the commonest extra-articular manifestation. I will describe eye manifestations also, and that eye manifestation is not uveitis. Guys, in majority of rheumatic conditions, the eye manifestation is uveitis, iridocyclitis, not in rheumatoid arthritis, where you will notice that the extra-articular is the ophthalmic manifestation would be keratoconjunctivitis sicca. I'll jot it down in a while, but I decided to just highlight these peculiarities which you also have to be aware of as point number 5, 6, 7, 8. And rheumatoid nodules location is forearm, sacral prominences, and then would be with respect to the Achilles tendon. Apart from this, extra-articular manifestation could be in the form of secondary Sjogren syndrome. I would recommend you to listen to Sjogren syndrome, where I've described anti-Ro antibodies. I've mentioned the diagnostic criteria, and the classical findings of Sjogren syndrome would be dry eyes and dry mouth, where we'll be doing Shermer's test to evaluate for the dry eyes in the patient. Apart from this, another extra-articular manifestation to be remembered would be interstitial lung disease and pulmonary nodules. With pulmonary nodules, the moment I'm writing it, I think what is coming to your attention is Kaplan syndrome. Yes, we do have a USMLE coaching that is Kaplan, KAP, but we'll talk about Kaplan syndrome, CAPLAN, in the subsequent slide, and that's with respect to the rheumatoid nodules. And these rheumatoid nodules are inflammatory, so they can break down. And they can break down to cause a exudative pleural effusion. So do not be surprised if in an MCQ rheumatoid arthritis he talks about pleural effusion, which is exudative in nature, and that gives it leverage to the examiner to ask you with respect to Light's criteria. Remember Light's criteria in pleural effusion, where we talk about transudative versus exudative, and we talk about the protein values and the LDH values per se. So I'm going to talk about the same thing in my subsequent slide as well. But why we are focusing on this is because in hardcore general medicine questions, most MCQs in general medicine will begin by not asking you the classical features of the disease. I mean, obviously this you have to be aware of all the routine data, but a large number of questions would try to test you with respect to extra-articular manifestations, which I'm focusing at the moment. And then would be AOCD, that is anemia of chronic disease, where the standard data would be, you are aware that anemia of chronic disease can be both microcytic hypochromic as well as normocytic normochromic anemia. That microcytic hypochromic is a late manifestation. Usually we diagnose the disease much more earlier than that. So if you're stuck up in a question where they ask you, and this is itself a question in anemia of chronic disease, which is a common presentation, microcytic hypochromic and normocytic normochromic both will be given in the MCQ, and your answer is going to be given as normocytic normochromic anemia. These are a couple of peculiarities which I want you to focus on, especially with respect to point number 8, which will be asked in hardcore general medicine questions. Whatever I say next is an extension of point number 8 only. The ophthalmic manifestation of this condition should not be answered as iridocyclitis. Rather, the manifestation should be answered as keratoconjunctivitis sicca. Other manifestations that can be seen are in the form of scleritis and episcleritis, but majority of the time the examiner wants to hear this word. Even in ophthalm, this question has been asked. Extra-articular ophthalmic manifestation of rheumatoid arthritis, the data is right before you, keratoconjunctivitis sicca. Then this disease can involve the salivary glands as well. So xerostomia, that would be dry mouth, can be a presentation. And because of the dry mouth, dental caries can follow, because the growth of Streptococcus mutans bacteria will occur, because saliva has bactericidal properties. So because of this xerostomia, periodontitis can occur in these patients, or even frank dental caries could be developing. Poor oral hygiene can be developing. Then we'll talk about lung manifestations of this condition. As I explained to you, there would be presence of rheumatoid nodules with respect to the pleura, and the breakdown of these would result in development of a exudative pleural effusion. So the lung involvement can be asked in the form of pleuritis. The inflammatory nodules will break down to cause a pleural rub, and then subsequently a exudative pleural effusion satisfying the Light's criteria, where the pleural fluid protein will be more than 0.5 and pleural fluid LDH will be more than 0.6. The fluid will be having high viscosity and will have high fibrin and will clot on standing. Over and above this, even the parenchyma of the lung can be involved. So rheumatoid arthritis can be contributing to development of interstitial lung disease. And here he will ask you which variety would be seen. So it would be usual interstitial pneumonitis, or it can be NSIP, that is non-specific interstitial pneumonitis. Between the two varieties, your first answer would be given as UIP, the usual interstitial pneumonitis. And the lung involvement of these patients is Kaplan syndrome. In Kaplan syndrome, we will be having association with pneumoconiosis, that is coal workers pneumoconiosis. Along with this, there would be presence of, as we've discussed, rheumatoid nodules. So the combination of the two, Kaplan, the KAP is obviously the USMLE coaching, but we're talking about Kaplan syndrome, which would be coal workers pneumoconiosis, written in short as CWP. So lung involvement, I mean, the examiner would love to ask about it. Then they would love to ask you regarding the cardiac manifestations of the disease as well. And considering their importance, let's do an ink change and try and remember the cardiac involvement of these patients as well. In fact, one of the leading reasons for death in patients with rheumatoid arthritis can be ischemic heart disease. The leading cardiac involvement in these patients is that these rheumatoid nodules could be occurring in the outermost layer of the heart as well, that is pericarditis. And then there could be even a pericardial effusion because of it. There could be pericardial friction rub that can be described. Then there would be ischemic heart disease, which is the most common cause of death with respect to patients of rheumatoid arthritis. Do remember this data, like in SLE, it's a kidney involvement. With respect to subsequently scleroderma, I've described it as interstitial lung disease and pulmonary artery hypertension. Here it is ischemic heart disease. Ischemic heart disease occurs in lupus also. Ischemic heart disease occurs in SLE also, but after 45 years of age. In SLE also, after 45 years, there's an accelerated cardiovascular mortality. Other cardiovascular aspects which are worth remembering would be one, arrhythmias. There could be tachyarrhythmias developing in these patients, even bradyarrhythmias due to rheumatoid nodules. And the valvular association to be remembered would be MR, mitral regurgitation. Mitral valve is anyway the commonest valve involved in all cardiac conditions. That's because mitral valve in our body operates at the highest hemodynamic stress. We'll now focus on the kidney involvement of this condition. One is going to be obviously amyloidosis, because you are aware any chronic inflammatory condition can contribute to secondary amyloidosis, but he wants to listen to what I'm writing at the moment, MGN. Even when you listen to the MGN part in the kidney, I've said which variety of nephrotic syndrome is associated with autoimmune disorders. The answer is MGN. MGN, guys, is associated with malignancy. It's a cancer associated nephrotic. And then MGN is also associated with chronic inflammatory diseases, including autoimmune disorder. The one we are talking about at the moment is RA. And along with MGN, as I explained, there would be amyloidosis. And both of these would be contributing to a nephrotic range proteinuria. So you can understand why we are discussing this. Hardcore general medicine data for rheumatoid arthritis. So the question will begin by describing those small joints of the hand involvement, bilaterally symmetrical, piece of cake. That's never an issue. It is remembering this particular slide, this rheumatoid ladies diagram that I'm trying to represent before you is one of paramount importance. And now let's look at a couple of findings that can be seen on general physical examination. One, with respect to Achilles tendon, we might be able to see these rheumatoid nodules. I did explain to you, rheumatoid nodules can be seen on the skin, they can be present in the heart, they can be present in the lungs, and the inflammatory breakdown of this would be responsible for exudative pleural effusion. Apart from this, purpuras can be seen, that's an immunological manifestation. Purpuras can be seen on the extremities of these patients. Then even genitals are involved, like in a male patient, we usually read about testicular involvement, and therefore hypoandrogenism can be also be seen in these patients. So there is no depth of data that can be asked to you in the exam, but yep, the ones that I mentioned, especially the lung involvement, the heart involvement, and the kidney involvement are must to be remembered features for this particular condition. Currently in these patients, we also find that the bone densitometry reports will be showing a T-score or a Z-score less than minus 2.5 standard deviation. That is presence of osteoporosis as well, which is an additional feature. Plus hematological features would be AOCD, that is anemia of coronary disease, where I've already explained to you the type of anemia that is seen is normocytic normochromic anemia. Whenever you are studying this topic, rheumatoid arthritis, I would like you to mainly, whenever you are revising this, obviously first time you're listening to it, you listen to the whole thing, but when you're revising this disease per se, I would recommend you to mainly focus on this diagram or try to draw this diagram and fill up maximum number of details here. And what are the details to be remembered? Let's do a quick recap in this case. Remember eye manifestation. That's going to be keratoconjunctivitis sicca. Do not answer iritis. Then remember lung involvement, especially Kaplan syndrome and the inflammatory pericardial pleural effusion that would be satisfying the Light's criteria. The Light's criteria are discussed in pleural effusion, so I'll not get into them again. The lung involvement can be interstitial lung disease, then can be heart involvement. The rheumatoid nodules, just like in sarcoidosis, no, those non-caseating granulomas can be causing arrhythmias and causing a pericarditis. I'm today teaching you rheumatoid nodules can be involving the heart as well. Therefore, pericarditis, arrhythmias can be described, though ischemic heart disease leading cause of death, and the kidney involvement here could be nephrotic syndrome. Which variety of nephrotic syndrome? Options would be like FSGS. You are aware focal segmental glomerulosclerosis is the commonest cause of nephrotic in adults, but for rheumatoid arthritis, you're going to answer as MGN. So autoimmunity associated with nephrotic is the one which is described here. Then secondary amyloidosis. So these are like couple of hardcore general medicine data which is likely to be asked in the exam for this particular topic. We'll now focus on classification criteria for diagnosis of rheumatoid arthritis, and a mnemonic that can be used to remember the manifestations is JSAD. After all, there's a joint involvement which is making the patient feel sad, and let's look at the features now. J would be joint involvement, S would be serology, A would be acute phase reactants, and D would be duration of symptoms. By joint involvement, we will first have to mention whether it is large joint or whether it is a small joint involvement, though classically it is small joint involvement seen in this condition. But as I've explained to you, even the small joints of the foot can be involved, even shoulder and knee joint can get involved in this condition, especially in monoarticular variety of rheumatoid arthritis. Then from the serology perspective, there are two tests. Test number one is RA factor. RA factor can be false positive in 5% of normal population. If a test can be false positive in normal population, can you use it for diagnostic purposes? Absolutely not. As a result of that, RA factor is not the best way for diagnosis of this condition. If they ask you in the exam which blood test would be best suited for diagnosis, then it is anti-CCP antibody, that is cyclic citrullinated peptide antibody. In some MCQs, however, this antibody can also be written as ACPA, but traditionally in the textbook, the word written is CCP, that is cyclic citrullinated peptide antibody, which helps in diagnosis of this condition. In the classification, you will read reports like negative or low positive or high positive because the titers of these antibodies can be variable. Then the acute phase reactants are easy to remember. That would be erythrocyte sedimentation rate and C-reactive protein. And as far as duration of symptoms are concerned, as I've explained to you already, that we can make a diagnosis even before 6 weeks, but to give more credibility to the diagnosis and to see the evolution of the disease, we should monitor a patient for a duration more than 6 weeks, so that, though we can make a presumptive diagnosis earlier also, but if we monitor the patient, we can see the evolution of how many joints are getting involved in this patient. So JSAD criteria are classification criteria for diagnosis of rheumatoid arthritis. Value more than 6, though they'll not ask you to score it, but JSAD value more than 6 is sufficient for diagnosis of this condition. And one more peculiarity that I would like to remind you from Bailey and Love, that is Felty syndrome. In Felty syndrome, you will read about rheumatoid arthritis. This would be associated with splenomegaly and neutropenia. And I just thought to mention it on this particular slide since we were just mentioning a easy detail in the form of JSAD for this one. I did not mention Felty syndrome in the previous slide because there we were talking about the more common extra-articular manifestations, but though this is given in Bailey, so I thought I should mention regarding Felty syndrome as well. In fact, patients of rheumatoid arthritis will also be having an increased risk of leukemia as well as lymphoma as well. Like if they ask you what is the commonest type of lymphoma seen in rheumatoid arthritis, your answer would be same as for ordinary people, that is diffuse large B-cell lymphoma. So I can just add this here that the hemat manifestations that can be seen in these patients can be in the form of lymphoma, or these patients can be having leukemias as well. So hematological malignancies can also be seen in these patients along with the Felty syndrome, which is a rare manifestation worth remembering. So next I made a list of tests that I'll be writing for diagnosis of this condition. That would be acute phase reactants in the form of ESR and CRP. RA factor, as I explained to you, RA factor is IgM antibody linked to FC portion of IgG. That's itself a microbiology based question. It is which antibody? Your answer would be IgM attached to FC segment of IgG antibody. and because it can be biologically false positive in 5% of normal population, so it is only a screening tool and can be negative in a substantial number of patients as well. Therefore, for diagnosis, the main test to be done would be anti-cyclic citrulline peptide antibody, also called as ACP antibody, to pick up the damage in the joint. Like the patient is complaining of damage in the wrist joint or complaining of pain in the wrist joint or at the MCP. What are the tests or imaging that I can write? In earlier times, we were doing X-ray, but you can understand that X-ray will pick up changes fairly late. So for early identification of imaging of the wrist or the imaging of the involved joints, what test I can write? I can do a MRI, or I can do an ultrasound of those joints, or I can do obviously a standard X-ray. But if they ask you which imaging modality is preferred for rheumatoid arthritis, nowadays from orthopedics perspective, all they write is MRI for all cases, because that's easy to identify. We can identify early changes as well. That's why MRI is recommended. Point number 5 is only for academic reasons. Synovial fluid aspiration. In real clinical practice, we'll not be doing it. But in case we do a synovial fluid aspiration, we will be getting inflammatory findings in this particular case. The number of neutrophils that can be present is up to from 5,000 to 50,000 neutrophils. I mean, when you read that number, no, you start thinking in terms of something like septic arthritis. But the septic arthritis, the number will go into lakhs. It would not be in 50,000. It would be much, much higher than that. It would be like 5 lakh neutrophils present. So in this particular case, it would be inflammatory changes that are present. Contrast this from osteoarthritis. Point number 5 is only from academic reasons. In real practice, nobody would do that. For osteoarthritis, less than 2,000 cells would be present. Less than 2,000 cells would be present, and majority of them are anyway going to be neutrophils. But if it's 5,000 to 50,000 neutrophils, that is inflammatory synovial fluid present. This is in contrast to, I would say, if there is pus present, if there is going to be septic arthritis present, where the values would go up into lakhs as well. The synovial fluid aspiration test is mainly being done in those cases so that you can do a polarized microscopic examination, especially in those cases where there is a MTP involvement. So I would like to rule out the possibility of gout in these cases. And in the X-ray of the foot, like if there is a atypical presentation, if there is going to be pain in the small joints and it is the MTP that is involved, then in the X-ray of the foot, where would you see the radiological changes? Like in acute gout, you will be reading what changes in the first metatarsophalangeal joint, but in this particular case, it is the lateral aspect of the fifth metatarsophalangeal joint which is to be remembered. Point number 5 and 6 is for only academic reasons. Otherwise, routinely, I would say they would like to focus on the traditional data for diagnosis of this. And I'll repeat the statement once again. In gouty arthritis, there would be a trigger present. It would be binge drinking. It could be drugs. It could be ATT drugs consumed by a patient like paracetamol. It could be alcohol, which impairs the excretion of uric acid from the body, and the uric acid levels will spike in the joint space. And that's why the acute attack of gout can be triggered. Or it could be like usage of diuretics in a hypertensive patient, and thiazide diuretics tend to increase uric acid. So there would be triggers given in a question. Then he's going to describe regarding the MTP involvement, and this is going to be only in the first MTP, whereas in this case, multiple small joints of the foot would be involved, and most of the time, the radiological finding can be seen in the lateral aspect of the first MTP, which is targeted first, but other joints can also be involved in these patients. Coming to the treatment of rheumatoid arthritis, the main DMARD that we're going to use is methotrexate. It will cause adenosine release and has an anti-inflammatory action. As far as the role of painkillers is concerned, it's only adjunctive therapy. Steroids use is discouraged, or usage of steroids is discouraged. Triple therapy has been asked in the recent exams extensively. Traditionally, we did triple therapy with H. pylori, where we used 2 antibiotics like clarithromycin, amoxicillin with PPI like pantoprazole. But here, the triple therapy that we're talking about is MTX, is methotrexate. Along with this, we're going to use a drug which is taught even in inflammatory bowel disease, that is sulfasalazine. And the third molecule is hydroxychloroquine. Hydroxychloroquine became famous at COVID times. You are aware that hydroxychloroquine was being used initially for both preventing as well as treatment of COVID-19, though subsequently ICMR and WHO, they changed the recommendations. The same immunomodulatory drug is a part of the triple therapy with respect to rheumatoid arthritis. It can contribute to retinal toxicity, so the dose adjustments have to be done. It can also cause a QT prolongation, and therefore it has to be prescribed in care with especially those patients who are having cardiovascular issues. Remember, in rheumatoid arthritis, the leading cause of death was ischemic heart disease. If this triple therapy is not causing a remission, we have a step up also, and the step up would be that along with methotrexate, we can discontinue the remaining 2 drugs and add a biological. What are the biological DMARDs we can be using? The mnemonic is ACE-IG. From ACE-IG, what we can remember is one is adalimumab. Then the next one to be remembered would be certolizumab. And the third one is etanercept. As far as I is concerned, while I write it infliximab, I have described infliximab even in inflammatory bowel disease. It's a tumor necrosis factor alpha antagonist basically. So infliximab, now you are aware for usage in inflammatory bowel disease. I've described it in ankylosing spondylitis as well, and is currently being discussed in management of rheumatoid arthritis. G would be standing for golimumab. So these are the drugs. Let's just do a quick revision here. Adalimumab, certolizumab, then etanercept, then is infliximab and golimumab. So ASIG is the mnemonic for it. The interleukin 6 inhibitor became again famous at the time of COVID-19, especially in cytokine storm, which was being caused by COVID-19. We were giving tocilizumab. It was in the recommendations for a very long time. Subsequently, it was removed also in peer-reviewed case control studies. Tocilizumab has no role for management of cytokine storm in COVID-19, so it was removed. But then interleukin 6 inhibitors play a role with respect to pathogenesis of rheumatoid arthritis, which is why the usage of the same is mentioned. And then among the targeted synthetic DMARDs, the drugs which are mainly used are JAK inhibitors. The first one that I'm writing is a JAK1 and a JAK3 inhibitor. This would be tofacitinib. This is a JAK1 as well as JAK3 inhibitor. The second one is baricitinib, which is JAK1 and JAK2 inhibitor. And the problem with the usage of these drugs is that they increase CV mortality. Remember, the leading cause of death with respect to rheumatoid arthritis is ischemic heart disease. The side effects of these two molecules, which have recently come to notice on clinical trials, is one, enhanced CV mortality. Remember, in rheumatoid arthritis, ischemic heart disease is one of the leading causes for development of death. Second is risk of malignancy is also increased with the usage of JAK inhibitors. Tofacitinib is a JAK1, JAK3 inhibitor. Baricitinib is JAK1 and JAK2 inhibitor. These are targeted synthetic DMARDs which are used along with biological DMARDs and are used as a step-up therapy in case the initial triple therapy is not working. How do we know that there is a remission? Well, the remission can be determined on the basis of values less than 1, tender joint count less than 1, swollen joint count less than 1, CRP values of less than 1 nanogram per ml. And then there is a questionnaire which is to be filled on the basis of response from the patient, and the patient global assessment value is also turning out to be 1. So there's no special effort that is required. All I'm trying to say is that the disability which was present in both hands of the patient to the level that she's not able to hold a toothbrush, her grip strength was substantially reduced, and she was not able to do her household chores, that disability has substantially reduced, and we'll be able to prevent the crippling deformities in the hands of these patients with the usage of the drugs which are mentioned on the current slide.